Good morning. I extend a very warm welcome to everybody present here. Today in the clinical grand rounds, the Department of Haematology will be presenting pregnancy in hematological disorders. So pregnancy in patients who have pre-existing hematological disorders, they happen to be extremely challenging. They require a multi-speciality collaboration and a very meticulous follow-up. The primary issues that a patient comes to us with is after therapy, they want to conceive and start or complete their family. And with an ongoing hematological disorder, they are now pregnant or they wish to experience motherhood. So the primary challenges in women of reproductive age group we already know happens to be anemia. And in Uttar Pradesh in reproductive age group alone, the incidence happens to be 45.9%. Anemia per se increases the risk of all complications during pregnancy. But in hemoglobinopathies, the primary issues that we face is that this anemia happens to get exacerbated. Pregnancy is already a prothrombotic state, and with the presence of an underlying hemoglobinopathy, there is a higher incidence of thrombosis and thereby an increased risk of MMR, infant mortality rate, abortions, stillbirths, as well as low birth weights. We already have national health programs like Anemia Mukt Bharat, which aim to decrease the incidence of anemia and thereby decrease the maternal as well as infant mortality rate. Hemoglobinopathies have already been discussed. Aplastic anemia in pregnancy, enzymopathies, red cell enzymopathies like hereditary spherocytosis, rarer causes like paroxysmal nocturnal hemoglobinuria, as well as anemia of chronic disease can also be seen in these cases. Coming to a very brief overview, we'll basically be discussing it as non-malignant comprising 62% and malignant comprising 38%. So pregnancy in non-malignant hematological disorders, we'll be doing a case-based study, a decade of experience of the hematology department, where we'll be discussing gestational and ITP, thrombocytopenia and ITP, a single case of von Willebrand disease, and thrombophilia cases like PNH and protein C deficiency. In the malignant hematological disorders, we will be covering a majority, the chunk of our patients which comprise chronic myeloid leukemia and single 2 cases of acute leukemias in pregnancy. I now ask Dr. Prisha to take over.
Good morning, respected teachers and colleagues. Discussing thrombocytopenia in pregnancy, the majority of the cases that we come across, 74% of them are usually gestational thrombocytopenia, with 4% of them falling under the immune category and 21% cases precipitating because of the hypertensive-related disorders like eclampsia and preeclampsia, with 1% being other cases like TTP and HUS. Coming in briefly about the differential diagnosis of thrombocytopenia in pregnancy, talking about the isolated causes of thrombocytopenia, mainly dealt with primarily hematological department. It is gestational thrombocytopenia, ITP in pregnancy, and type 2B von Willebrand disease. However, thrombocytopenia in pregnancy can be associated with other systemic disorders as well. In particular, pregnancy-specific, that is preeclampsia, HELP, and acute fatty liver. Non-pregnancy specific like TTP, HUS, APLA, various viral infections, and nutritional deficiency. In our OPD, we usually see these patients as two most common case scenarios. That is, Mrs. A here was a 26-year-old primey who had some mild petechiae and was referred to as an 8th week of gestation with a platelet count of 50,000. On evaluation, her peripheral smear was suggestive of giant platelets, and we did evaluate her for other causes, as I mentioned before. And we also have Mrs. B, who's a 20-year-old primary, presenting to us in her 3rd trimester with asymptomatic, no bleeding manifestation with a platelet of 98,000 with no other comorbidities and all other workup negative. So these apprehensive A and B females have doubts like whether they'll have a normal baby, what are the medications that they can take, whether they need to donate blood, and if they can deliver normally. As a hematologist, the challenges we face are to treat or not to treat them, what is the target platelet count that we should maintain in all the trimester, and what are the treatment options that we can offer to our patients. So coming to queries one by one, Mrs. B here has a condition called gestational thrombocytopenia, which is seen in 5 to 8% of healthy pregnant females, which is due to increased plasma volume and increased platelet clearance or a combination. Most commonly seen in 3rd trimester, like our female who presented at 28th week of gestation. Only less than 0.1% of females have a platelet of less than 80,000. It is not a cause of maternal bleeding or neonatal thrombocytopenia. Platelets before pregnancy and postpartum are returned to normal, and it does not require any kind of treatment. Mrs. A here has condition called ITP in pregnancy, which is seen in 3% of pregnancies. Platelet count can go as low as less than 50,000. It is an autoimmune disorder. Thrombocytopenia can be present before conception or very early in pregnancy, like our female who presented at 8th week of gestation. It is a diagnosis of exclusion and it does pose a risk of maternal bleeding and fetal thrombocytopenia. Now, after diagnosing, do we need to treat all of them? So the indications for treatment in the first 2 trimesters are like any other non-pregnant female, where if the patient with ITP has bleeding or has a platelet count less than 30,000, or if near-term willing for a vaginal delivery, a platelet of less than 50,000, or if going for LSCS, platelet of less than 80,000. However, no treatment of ITP in pregnancy has been approved by regulatory agencies. The lowest effective dose of prednisolone and IVIG have been the safest use options and age-old. So coming back to our cases, Mrs. A, who had presented to us at 8th week, on further follow-up after 2 weeks at 10th week of gestation, she had a platelet count of 30,000, where she was diagnosed with acute ITP and started on the lowest possible dose of prednisolone. At 34 weeks of pregnancy, she had a platelet of 25,000, thus was administered IVIG at 400 mg per kg. At 35 weeks, with a platelet of 60,000, she delivered a healthy baby with no complications. Mrs. B, who had come to us in 3rd trimester with a 98,000 platelet, she was diagnosed as gestational thrombocytopenia. She was simply observed for the rest of her gestational period. At 37 weeks of gestation, she had a platelet of 96,000, and at 38 weeks of gestation, she delivered a healthy baby with no complication. Coming to a brief synopsis about the treatment options that we have offered to our patients, corticosteroids and IVIG, as we have discussed in these 2 cases. Talking in brief about them, corticosteroids, classically when we speak, are given at a dose of 1 to 2 mg per kg in immune disorders. However, in pregnancy, corticosteroids are put to use at the lowest possible dose in order to avoid the side effects like hypertension, hyperglycemia, psychosis, and osteoporosis. And IVIG, on the other hand, can be given for 0.4 gram per kg per day for 5 days. The response with corticosteroids is seen within 7 days and IVIG response as quick as 1 to 3 days. That is why IVIG is preferred in the peripartum period. What about other treatment options that can be offered to our patient? Talking about azathioprine, the data regarding azathioprine doesn't per se come from patients with ITP in pregnancy, but there is ample safe data from other immune disorders which can be extrapolated, and thus azathioprine is a safe option for our patients with ITP in pregnancy. The other TPO agonists, that is L-Thrombopac and Romiplostin, available in the market for treatment of ITP. L-Thrombopac, however, has no safety data in pregnancy, thus we prefer not to use L-Thrombopac. Romiplostin, however, has various anecdotal case reports which have shown a successful and safe use of the drug. However, the jury is not out yet. So talking about our experience of the last decade, we had a cohort of 41 females ranging in age from 22 to 39 years of age, mean age being 27. 27 of them being multigravida and successfully maintaining a platelet of more than 50,000 in all 3 trimesters, with a maximum cohort comprising 56% of chronic ITP patients, that is patients who were our follow-up and wished to experience motherhood. We observed that thrombocytopenia with grade 1, that is more than 75,000, and a grade 4 thrombocytopenia of less than 25,000, grade 2 and 3 lying in between. We had 7 and 8 females respectively in the first and second trimester who had grade 4 thrombocytopenia, and 5 females in 3rd trimester with grade 4 thrombocytopenia. So with the above diagnostic evaluation, what are the treatment options that we offer to our patients? Before conception, we can see 29% of our females were on azathioprine-based long-term therapy and 10% were on TPO agonist therapy. However, during the period of gestation, most of our patients went on to receive prednisolone, where we can see 9 of them required IVIG in addition and 1 continued to receive azathioprine in addition to it. So with a safe treatment being offered, to the interest of an obstetrician and to the patient herself, there's always a doubt that with the low platelet count, there can be a possibility of bleeding, antepartum, postpartum, and followed by a fetal loss. So we would like to emphasize that in our cohort, there was no female who had APH, PPH, or any other systemic bleed. However, there was 1 patient who did have some petechiae and ecchymosis. Talking about other medical complications, since we use prednisolone in most of our patients, 6 of our females did have prednisolone-induced deranged blood sugars, which was managed successfully with insulin therapy. Now, so we can say that pregnancy, if it is observed and monitored and under supervision, ITP in pregnancy is a safe disease. So with this, can Mrs. A and B deliver normally? From a hematological point of view, I would say that obstetric indication is the only thing which should guide the mode of delivery. and NSAIDs with a platelet count of less than 1 lakh should be avoided. Several studies have proved that epidural and spinal anesthesia in patients with ITP is safe with a platelet count of more than 80,000. Thus, our target is more than 80,000 for a patient undergoing LSCS and more than 50,000 for a patient undergoing normal vaginal delivery. In our experience, we had 21 females who delivered via LSCS and 18 females who delivered normally. So, in the peripartum period, the most dreaded, fearful thing is the low platelet count in the peripartum period. Females who had grade 3 thrombocytopenia in the peripartum period, 4 underwent LSCS, where only 1 required IVIG, 6 underwent normal vaginal delivery, only 1 requiring IVIG. And the most dreaded and fearful, grade 4 thrombocytopenia, that is less than 25,000, where we had 4 LSCS and 1 normal vaginal delivery, where we can see most of them requiring IVIG and only 1 requiring SDP transfusion. Now, with this, our neonates born to our cohort are always at a risk that whether they can themselves have a low platelet count or can suffer any major bleeding manifestations. In our cohort of 41 patients, the mean birth weight of the newborn was 2.8 kg. We observed 41 healthy births with 23 males, and out of the 41, only 3 patients had neonatal autoimmune thrombocytopenia and none of them had ICH, with maintaining a fetal platelet count on an average of 1.23 lakh. Thus, of late, it is said that in patients with thrombocytopenia and pregnancy, we should avoid forceps delivery or any vacuum extraction to avoid the complications like this. Now coming to another spectrum of interesting cases, that is pregnancy in women who have inherited bleeding disorders. So these females can be carriers of hemophilia, von Willebrand disease, or some other coagulation factor deficiencies like factor 11 and etc. Where we can see major chunk of these females will be into the von Willebrand disease, and major cases reported are in the von Willebrand disease spectrum. So here we have an amazing case. Case C, Mrs. 20-year-old, 25-year-old female who had a history of being menorrhagic and was on off and on use of tranexamic acid, who had to undergo an emergency laparotomy for acute abdomen, which was complicated by hemoperitoneum, and thus she was diagnosed as von Willebrand type 3. And she was under our follow-up, and in around 2022, she presented to us that she wanted to get married and start a family and was thus counseled regarding the same. And in 2023, she had a spontaneous conception and was planned for elective cesarean section as patient was not willing for trial of labor. We followed her up during the pregnancy and she did not receive any factor replacement thanks to her pregnancy state, which is a procoagulant, and the bleeding tendency of the disease herself. But in the peripartum period, as she was planned for elective LSCS, fearing a dreaded complication of excessive bleeding with a baseline von Willebrand antigen of less than 3% and a factor rate level of 2.85%, we provided her factor replacement, targeting 100% correction 1 day prior to the procedure and tapering it off within the next 6 to 7 days, maintaining the hemostasis. On 8th May 2023, she delivered a healthy baby with no complications. Now coming to another challenging spectrum that we had, that is Mrs. D, who's a 22-year-old female. She came to us in 2021 with complaint of hematuria on and off with a hemoglobin of 12, with leukopenia and a raised LDH. On evaluation, her bone marrow was suggestive of a mildly hypocellular marrow with erythroid preponderance, and PNH clone on blood flow cytometry was suggestive of a major clone, with type 3 RBC being 66.7%. She was thus diagnosed with classical PNH, and she was managed with lowest possible need-based steroid therapy, and no regular anticoagulation was advised. As a therapeutic treatment, she was advised to undergo allogenic hematopoietic stem cell transplant and was advised family planning in view of her age. However, in November 2022, she presented to us with a wish that she wanted to start a family, and she was counseled regarding the same as about the risk associated. As in world, there are hardly 190 pregnancy and documented cases in pregnancy with PNH, with only 1 documented case in India, where 130 of the females had a safe pregnancy outcome with the use of only eculizumab, and thus with no much defined guidelines and high risk challenges, that is high risk of thrombosis of the disease itself and the state of pregnancy, and a possibility of exacerbation of anemia because of acute hemolysis during the time, and the non-availability of targeted therapy in our country. With the above information and counseling, in March 2023, our patient had a spontaneous conception, and she was monitored under the Department of Haematology under guidance of respected Sir Sanjeev with treatment with the lowest possible dose of prednisolone and a prophylactic low molecular weight heparin, And with a safe gestation and no complications during gestation, in December 2023, she delivered a healthy baby with no immediate intra or postpartum complications. We had another interesting case, Mrs. E, who was a protein C deficiency carrier who was managed beautifully under the department of MRH, and for which I would like to request Dr. Monali from MRH to discuss the case and put light on it. Thank you.
Good morning, everyone. So this is an interesting case where a child affected with hereditary thrombophilia due to protein C deficiency, who was an 8-month child and was managed in hematology department. This is a pedigree of the family being discussed. This is the index case who had hereditary thrombophilia due to protein C deficiency. So this is the clinical exome report of the affected individual, where you can see the individual was compound heterozygous for the disease, which is protein C deficiency, and it is an autosomal recessive condition. This is the confirmation by Sanger sequencing. The patient, the mother of this child, had conceived again while managing this child, and then she was concerned about her ongoing pregnancy and upcoming child. So the targeted mutation analysis of the couple was done, and the couple was found to be carrier for the same disease, and the counseling was done. The recurrence risk is 25%, and in that pregnancy, chorionic villus sampling was done, and the fetus was found to be affected, and the couple had opted for medical termination of pregnancy. In third pregnancy, she had come to us and was booked with us since beginning. We had done chorionic villus sampling at 12 weeks of gestation, and the fetus was normal for the disease. The antenatal period was uneventful. She delivered with us at 37 weeks, 2 days of gestation via cesarean section. Male baby, it was a male baby, 2.9 kg, and alive and healthy, 10 months old now. So learning from these cases, pregnant women presenting in hematology department may be at risk during pregnancy due to the disease per se, while a child being presenting in a hematology department gives opportunity to the family to have a healthy future sibling. So with a good interdepartmental coordination, a family as a whole is looked after to diagnose the disease, tell about the recurrence, means of prenatal testing, and above all, a healthy child. Thank you. Now I hand over my mic to Dr. Mona ma'am for further presentation.
We have come halfway through our presentation, now shifting gears to discuss pregnancy in malignant hematological disorders. Here also we will be doing a case-based discussion under the headings of acute leukemia and chronic myeloid leukemia. The malignancies that we encounter in women in fertile age group are mostly lymphomas, which can comprise of Hodgkin's lymphoma and non-Hodgkin's lymphoma. We can come across acute leukemias and chronic leukemias. In acute leukemias, we see acute myeloid leukemia, acute lymphoblastic leukemia. In chronic leukemias, the most of our patients are of chronic myeloid leukemia, and rarely we see essential thrombocytosis and polycythemia vera. So when we decide the treatment in pregnant females, it mainly depends on the trimester in which they present to us. Surgery being safe in all the trimesters, and radiotherapy to the pelvic region contraindicated all throughout. Chemotherapy is trimester-based, being contraindicated in the first trimester. So, as we have discussed in the previous slides, the safety of various modalities in brief, now touching upon other important issues like mode of delivery, which is based solely on the obstetric indication. And the chemotherapy should be timed in such a way that the count recovery of the last chemotherapy coincides with delivery. And the neonatal care should include screening the baby for any chemo-related toxicities. Lastly, breastfeeding remains contraindicated during chemotherapy. Now I call upon Dr. Aishwarya to take us through the case-based scenarios.
Thank you so much, ma'am. In our decadal experience of pregnancy in hematological malignancies, we came across 26 cases. The the majority comprising of chronic myeloid leukemia, and a scattering of few cases like acute lymphoblastic leukemia, acute myeloid leukemia, an APML, and a multiple myeloma. So let's go on to their management one by one. Acute leukemias in pregnancy, the majority of which is usually acute myeloid leukemia, is managed trimester-wise, like Ma'am Mona had said. In the first trimester, like she had said, you should counsel for MTP as no chemotherapeutic drug is safe. And in the second and third trimesters, you should manage as normal guidelines say of giving 3+7 induction, which is daunorubicin and cytarabine. Like ma'am said, the count recovery should coincide with the date of delivery so as to prevent complications such as infections and bleeding. If the patient presents to you after 34 to 36 weeks, then you should consider for an early termination of pregnancy. Let's go on to our case. She presented to us at 12 weeks of gestation. She was a 24-year-old primey who presented with bleeding gums and pancytopenia for 4 weeks. Due to pancytopenia, she required a bone marrow which showed blasts, and on flow cytometry, this showed acute myeloid leukemia. She received antibiotics and blood products as supportive care, and NGS was sent for risk assessment. At 13 weeks of gestation, she was counseled for MTP, and at 14 weeks, her MTP was successful, and she received daunorubicin and cytarabine as 3+7 induction. Unfortunately, at 15 weeks of gestation, she developed fever and abdominal pain, which was suspected to be neutropenic enterocolitis or purpurine sepsis. An ultrasound abdomen was done, which was normal. Antibiotics were started. Once the patient's TLC and platelet improved, she became afebrile and was discharged. Till date, she is in remission and she is on consolidation therapy. So let's move on to the management of acute lymphoblastic leukemia. It is slightly different from acute myeloid leukemia, wherein the time for termination of pregnancy is further shifted to 20 weeks of gestation. This is because most of the drugs of acute lymphoblastic leukemia are not safe in pregnancy. Beyond 20 weeks of gestation, we are necessarily buying time by giving steroids and daunorubicin, and the same dictum applies. Termination should coincide with count recovery. So let's move on to our case. She also presented to us at 12 weeks of gestation. She was a 23-year-old G3P2L1A1 and presented with passage of blood in stool and was diagnosed with acute lymphoblastic leukemia in hyperleukocytosis. The patient's peripheral smear was as follows. She received cytoreduction with steroids and anti-TLS measures in the form of fluid, and allopurinol was started. She was counseled for MTP. However, at 15 weeks of gestation, because of high risk of disease and CNS positive status, she was started on steroids and daunorubicin. At 16 weeks of gestation, MTP was done successfully. Patient was continued on therapy, and at the end of induction, she was in morphological remission. Till date, she is in remission and now is on maintenance therapy. Now moving on to the majority of her cases, which was chronic myeloid leukemia in pregnancy. So the advent of tyrosine kinase inhibitors has been a game changer in the management of CML in pregnancy. CML has increased its overall survival by nearly 40 years after the advent of tyrosine kinase inhibitors. Therefore, the prevalence of women in reproductive age group have increased significantly, and all these women now wish to complete their family or experience motherhood. So from 2008, as you can see, the number of women with successful labor has increased. So you can have necessarily 3 case scenarios of CML and pregnancy. The first and the most dreaded being a patient who is pregnant, who is now diagnosed with chronic myeloid leukemia. The second one being a patient who is a known case of CML, now has an unplanned pregnancy and has unfortunately exposed her fetus to some amount of tyrosine kinase inhibitor. And the third one being a patient who is a non-case of CML, has achieved all her targets and now can have a planned pregnancy, in which we have seen through literature that once you stop the tyrosine kinase inhibitor, it will give you usually 36 months wherein the disease will not progress, giving us ample amount of time for the patient to conceive and continue with her pregnancy. So let's go on to these scenarios one by one. In 2023, we had a 39-year-old elderly primey who presented to us with 13 weeks of amenorrhea. She was referred to us in view of high TLC count. Her spleen on examination was 6 centimeters palpable. Her TLC was as high as 1.5 lakhs with a normal hemoglobin and a normal platelet count. Her peripheral smear showed a shift to left. Her BCR-ABL was done suspecting chronic myeloid leukemia, which came out to be positive, and she was diagnosed as CML in chronic phase. She was counseled for MTP. How we manage this case will be explained in detail in the future slides. Now let's move on to the second scenarios and second pregnancy. In 2022, we had a 33-year-old G1P1L0 who was diagnosed with CML-CP and started on imatinib. Her baseline BCR-ABL was 44, and she was counseled about the need for a planned pregnancy in order to prevent inadvertent TKI exposure. In 2024, she accidentally conceives and presents to us at 7 weeks of amenorrhea. The last case is slightly different from the second one, wherein the patient presents to us with a known case of CML-CP. Here, this patient has achieved all her milestones. Her BCR-ABL has been not detected for nearly 2 years. She wishes to conceive and have a planned pregnancy. Both these patients have similar doubts to her doctor, whether they can continue with their pregnancy or have a normal delivery. Only the second case has one additional query of whether those 7 weeks of TKI exposure will have any effect on her baby. So how do we manage these cases? The case will be based upon how and when they present to us. So if the patient is a patient who's pregnant and now presents to us with CML, you should counsel for termination of pregnancy in order to prevent the risk of disease exposure of the disease to progress. You can have some drugs with us in our arsenal like interferon alpha, leukapheresis, and hydroxyurea. These are mainly cytoreductive agents. Only interferon alpha has been shown to have some amount of disease-modifying activity. However, if the patient presents to us who's a known case of CML-CP and has an unplanned pregnancy, you should counsel for MTP. If they do desire to continue with pregnancy, the modalities of therapy will remain the same as in case H. The only difference being that she has now had an additional exposure of TKI. A planned pregnancy can only be considered if the patient is in molecular response. In this scenario, we stop the TKI, wait for a few weeks for the drug to wash out, and then continue with pregnancy. So our experience of 21 patients identified between 2014 to 2024, out of which 4 were diagnosed prior to pregnancy, during the pregnancy, and the mean age of these patients were 26 years with the range of 18 years to 39 years. As you can see, most of these patients presented to us in their first and second gravida. So they are all very motivated to continue their pregnancy and complete their family or experience motherhood. 7+2 of these patients presented in the second and third trimester. That is, most of these patients had already been exposed to imatinib. As you can see, 16 of these patients were conceived while on imatinib, and the median exposure was 12 weeks, with a range as high as 6 to 31 weeks. Most of these patients had already completed organogenesis. So what does imatinib really do to the fetus? Animal models have shown that it has some amount of abortifacient effect, and it can cause skull and bony deformities. There are human case reports which have hinted to similar defects, but there is a large number of studies which now show that accidental exposure to imatinib can still result in normal deliveries, healthy babies, and they have also seen that spontaneous abortion rates are nearly equal to that of the population. So what happened to our 21 patients? Like I mentioned, 17 were diagnosed prior to pregnancy. 16 of these patients were unplanned pregnancies, and 1 was a planned pregnancy. One of these four patients who were diagnosed during pregnancy had an intrauterine death due to renal agenesis, but this was prior to any TKI exposure. 3 of these 4 patients continued with their pregnancy who were diagnosed during the pregnancy. Out of the 16 unplanned pregnancies, 3 went for MTP. This is because their family was complete and for personal reasons. 13 of them continued with their deliveries. Out of the 3 patients who were diagnosed during the pregnancy, 1 required tyrosine kinase inhibitor. This was in the 3rd trimester, and this was to prevent disease progression, wherein it is considered relatively safe to be given. 2 of these patients received cytoreductive therapy in the form of hydroxyurea and interferon alpha. Monitoring of these patients is very, very important, and there should be a close coordination between the Department of Obstetrics and Haematology to monitor for any congenital abnormalities. BCR-ABL and CBC should be done every 4 to 6 weekly like it was done in these cases, and the frequency is always increased nearing the trimester. The mode of delivery is always dictated by the obstetrician. A vaginal delivery is preferred. Complications such as bleeding, thrombosis, and progression of the disease can be expected. Thankfully, 8 out of our patients had a vaginal delivery. 6 of these patients required LSCS due to obstetric indication. The fetal outcomes, like I mentioned, there has been a literature review in which 125 pregnancies of accidental exposure to imatinib were followed, and they found 9.6% of them to have malformations. But when compared to population controls, this was not really any significant difference between the two. Our data showed that in 16 pregnancies, none of our patients had any congenital malformations with a mean birth weight of 2.6 kgs. 2 of our patients were below birth weight, had less birth weight. The maternal outcomes were equally heartening. All mothers were alive and healthy. There was a loss of response in 6 patients requiring some amount of intervention. 2 patients were lost to follow-up. There was no antepartum, postpartum hemorrhage or thrombosis in any of our patients, and none of our patients progressed to blast crisis or accelerated phase. So what is the take-home message? Safe motherhood is possible in all patients with hematological conditions. Pregnancy in hematological conditions require multidisciplinary approach and regular follow-up. I would like to thank the Department of Maternal and Reproductive Health, Transfusion Medicine, Radiology, and Neonatology for their contribution. And thank you all for your patient listening.